So our lecture today is about blood transfusion. First, we're going to talk about blood and blood products. 2, about the indications for transfusion. 3, about the complications of transfusion. And 4, we're going to discuss briefly massive blood transfusion. There are approximately 50 million red blood cells units that are transfused annually in the United States. Physicians most commonly use hemoglobin concentration to decide when to transfuse. However, most guidelines emphasize that transfusion should be given for symptoms of anemia and should not be based on hemoglobin concentrations only. Now, the rationale for transfusion. Blood has a very important role in oxygen delivery, and there is a very important impact of anemia on morbidity and mortality. The body at rest uses approximately 250 cc of O2 per liter of blood. O2 delivery can fall with a reduction in any of cardiac output, hemoglobin concentration, and O2 saturation. Organs that are the most sensitive to hypoxia are the heart and the brain. So why should we transfuse? The answer I often get to this question is to increase the patient's hemoglobin. This is true, but this is important because of the equation of the oxygen content of blood. So the oxygen delivery to tissues equals cardiac output times oxygen content of blood. Talking now about the blood components. They're prepared from whole blood collection or apheresis. Whole blood is separated by differential centrifugation. What we can get is red blood cells, platelets, plasma, cryoprecipitate, and others. Others include some plasma proteins like IVIG, coagulation factors, albumin, growth factors, or colloid volume expanders. Apheresis may also be used to collect blood components. Whole blood can be stored at 4 degrees Celsius for up to 35 days. The main indication for whole blood transfusion is massive blood loss or trauma. When administering whole blood, a filter should be used as platelets and coagulation factors will not be active after 3 to 5 days. Donor and recipient blood must be ABO identical. RBC concentrate can be stored at 4 degrees Celsius for up to 42 days and can also be frozen. Indications. There are many indications for RBC concentrate like anemia, hypoxia, and others. The recipient must not have antibodies to donor RBC, and the usual dose is about 10 cc per kilo. It will increase the hemoglobin by 2.5 to 3 gram per deciliter. Usually can transfuse over 2 to 4 hours unless it's in the OR or as there's emergency blood loss. Platelets can be stored up to 5 days at 20 to 24 degrees. They should not be frozen. They contain leukocytes and cytokines. 1 unit per 10 kilo of body weight increases platelet count by about 50,000. The donor and the recipient must be ABO identical. Indications for platelet transfusions are 10,000 in a stable non-bleeding patient, 20,000 in an unstable non-bleeding patient, 50,000 in patient undergoing invasive procedure or actively bleeding. Certain procedure can require an actual platelet count of over 100,000, like neurologic or ophthalmologic or cardiac procedures. Plasma and fresh frozen plasma contain coagulation factors. They can be stored up to a year at minus 18 degrees or colder. Their indications are coagulation factor deficiency, fibrinogen replacement, DIC, liver disease, exchange transfusion, or massive transfusion. The plasma should be recipient RBC ABO compatible, and the usual dose about 20 cc per kilo to raise coagulation factors by approximately 20%. Cryoprecipitate. It's formed and collected when the FFP thawed at 4 degrees Celsius. After collection, it can be refrozen and stored up to 1 year at minus 18 degrees Celsius. The indication is fibrinogen deficiency or dysfibrinogenemia, VWF deficiency, factor 8 or 13 deficiency, or DIC. ABO compatible is preferred for cryoprecipitated transfusion, and the usual dose is 1 unit per 5 to 10 kilo of recipient body weight. One of the questions that comes most often in the boards are leukocyte reduction filters. It's used for prevention of transfusion reaction. Filter used with RBCs, platelets, FFP, and cryo. It may reduce RBCs by about 5 to 10%. It does not prevent graft versus host disease. So the main question becomes, when do we need to transfuse? There's an older study that was done in 2002 called Mortality and Morbidity in Patients with Very Low Postoperative Hemoglobin Level who Declined Post-Transfusion that predicted the mortality of patients with very, very low hemoglobin level. And the mortality for patients with a hemoglobin of 7 to 8 was 0%. The mortality of patients with a hemoglobin from 5 to 7 was 9, and it came and the hemoglobin for patients with hemoglobin of 3 to 5 was 30%. The lower the hemoglobin was, the higher the mortality was. What the study found is that there was no difference in 30-day mortality. The other main difference was that in healthy patients and in the young, which was defined as a age less than 55 years, transfusion actually increased mortality. These are the two graphs here. The first one shows the survival and the days in patients with an Apache score less than 20, which are the healthy patient. And you can see that the liberal transfusion strategy causes a higher mortality than the restrictive transfusion strategy. The second graph also here shows a mortality of 5.7% in patients who are less than 55 years with the restrictive transfusion strategy, and of 13% in patients with the liberal transfusion strategy. And the conclusion of the study was that a restrictive red blood cell transfusion strategy appears to be safe in most critically ill patients with cardiovascular disease, with the possible exception of patients with acute MI and unstable angina. Another study which is really famous is the GRID study. It's a prospective multi-center observational cohort study of almost 5,000 ICU patients in the US. It was designed to examine the relationship of anemia and RBC transfusion with clinical outcomes. Almost 95% of patients admitted to the ICU have a hemoglobin level below normal by day 3. In total, 11,000 RBC units were transfused, and overall 44% of patients admitted to the ICU received one or more RBC units while in the ICU. The results showed that RBC transfusion was independently associated with higher mortality. The more patients refused blood units, the higher their mortality. This next article covered relationship of blood transfusion and clinical outcomes in patients with acute coronary syndrome. Is an analysis of 24,000 enrollees in 3 large international trials of patients with acute coronary syndromes. It showed the association between transfusion and outcomes. The main outcome was actually 30-day mortality. You could see that in patients with acute coronary syndrome, the 30-day mortality was extremely higher in patients who received blood transfusion than in patients without any transfusion. This article, basically all these articles, actually showed that transfusing blood is not a benign thing to do. So when to pull the transfusion trigger? It should not be based solely on the hemoglobin number. Decision should consider the clinical scenario, the patient characteristics, and the symptoms. So, for hemoglobin less than 6, the transfusion is recommended. For hemoglobin between 6 and 7, the transfusion is likely recommended. And for the hemoglobin of 7 to 8, A restrictive transfusion strategy for stable patients should be used. You should consider transfusion only in postoperative or symptomatic patients that have chest pain, orthostatic hypotension, or tachycardia that is unresponsive to fluid resuscitation or congestive heart failure. For hemoglobin A to 10, transfusion is generally not indicated. Transfusion can happen in special circumstances like acute coronary syndrome, active ischemia, symptomatic anemia, active bleeding, or critically ill septic shock. The hemoglobin for hemoglobin dead transfusion is never indicated. Let's talk now about the transfusion complications. There are acute transfusion reactions, chronic transfusion reactions, and transfusion-related infections. The acute transfusion reactions include the hemolytic reactions, the febrile reactions, allergic reactions, trali, coagulopathy with massive transfusions, and bacteremia. So the acute hemolytic transfusion reactions occurs when incompatible RBC are transfused into a recipient who has preformed antibodies, usually ABO or H. RH. Antibodies activate the complement system, causing intravascular hemolysis. Symptoms occur within minutes of starting the transfusion. This hemolytic reaction can occur with as little as 1 to 2 cc of RBCs. A labeling error is the most common problem. This reaction can be fatal. Symptoms of acute hemolytic reaction are high fever and chills, hypotension, back abdominal pain, oliguria, dyspnea, dark urine, and pallor. So what do you do if acute hemolytic transfusion reaction occurs? First thing would be to stop the transfusion. 2. Apply the ABC. Maintain a good IV access. Monitor the blood pressure. Give a diuretic. Ablate blood and urine for transfusion reaction workup. And send the remaining blood back to the blood bank. What does the blood bank do? They check the paperwork to assure there is no errors. They check the plasma for hemoglobin. They repeat the cross-match. They send blood cultures. And they repeat the blood group typing. Labs found in acute hemolytic transfusion reactions: hemoglobinemia, hemoglobinuria, positive direct antiglobulin test, hyperbilirubinemia, and abnormal DIC workup. The second reaction we're going to talk about is the febrile non-hemolytic transfusion reaction. Basically, by definition, it's a rise in patient temperature of more than 1 degree C that occurs after a transfusion or during a transfusion. It occurs with approximately 1% of PRBC transfusion and approximately 20% of platelets transfusion. This febrile non-hemolytic transfusion reaction is caused by alloantibodies that are directed against the HLA antigens. So what to do in that case? Again, stop the transfusion is the first thing to do. Then use antipyretics, use steroids for severe reactions, and use of narcotics for shaking shields. For future considerations, may prevent the reaction with a leukocyte filter. You can use single donor platelets and washed RBC or platelets for future transfusion. The next reaction we're going to talk about is the allergic non-hemolytic transfusion. It may be due to plasma proteins or blood preservative anticoagulant. It's best characterized with IgA given to an IgA deficient patient with anti-IgA antibodies. It presents with urticaria and wheezing. In treatment for mild reactions, the blood can be continued. For severe reaction, transfusion must be stopped and may require steroids or epinephrine. One medication that can be given for prevention is an antihistamine. Now let's talk about transfusion-related lung injury, TRALI. It's a clinical syndrome which is similar to ARDS. It occurs 1 to 6 hours after receiving plasma-containing blood products. It's caused by WBC antibodies present in donor blood that result in pulmonary leukostasis. This treatment is supportive, and it has a high mortality. Massive transfusion can cause a lot of coagulopathy after transfusion of massive amounts of blood. Coagulopathy is caused by failure to replace the plasma. Electrolyte abnormalities can also occur. The most common ones is hypoglycemia, which is due to cited by drink of calcium. Bacterial contamination is more common and more severe with platelet transfusion. Because platelets are stored at room temperature. The organisms that have in platelets are gram-positive organisms, and the RBC are Yersinia and Enterobacter. The risk increases as the blood product age. Chronic transfusion reactions include alloimmunization, graft-versus-host disease, iron overload, and transfusion-transmitted infection. Transfusion-associated infections are hepatitis C, hepatitis B, HIV, or CMV. CMV can be diminished by local reduction, which is indicated for immunocompromised patients. The risk of transfusion-infectious disease reactions is very small. HIV is about 1 in 2 million, HCV is 1 in 1.6 million, HBV 1 in 220,000. Transfusion reaction, as a summary, an acute hemolytic transfusion reaction can be fatal. You need to stop transfusion. We need to monitor for symptoms and complete evaluation after a reaction. Febrile non-hemolytic transfusion reactions, diagnosis of exclusion. TRALI is an RDS-like reaction that can also be fatal. The main prevention methods are using filter, irradiation, and pre-medication.